Good morning, everyone. Welcome to New York for the monthly endovascular live case webcast. I'm Karthik Guja and I have with me Sardar Farhan, my associate. We are here to welcome you for a live case with Dr. Krishnan and Dr. Kapoor and his team, where they have brought a very interesting case this month with some new interesting devices coming into play. So before we move to the room for the live case, the previous cases have been archived into our website, so you guys can have a look at it. Please do ask us any questions, and we would be more than happy to answer it. The next live case is going to be on the last Wednesday of the month, the May 26th, as we always do. And before we jump on to our new room, room 6. Which we have just opened up this week, where Dr. Krishnan is doing the live case for the first time. So let's go on to the new room. Good morning, Dr. Krishnan. Good morning, Dr. Kapoor.
Good morning, everyone. Good morning, Sardar. We welcome you to the new room 6. We're very excited, Vishal, myself, and all of us, Dr. Gujar and Dr. Farhan. This is a wonderful Philips Azurian room that the hospital was kind enough to purchase for us and to help us take care of our patients. But we're very excited today to really, demonstrate a device that actually this is the first time we've gotten our hands on it. It should be very interesting to see the device, and we're going to learn along with you. We're very appreciative of the company sending us one of their representatives, Mr. Avi Posen, who's here to guide us through, some of the challenges in learning a new device, but he's been very kind in making time for us. But it's an exciting CTO crossing device, which I believe we'll have, and we'll go over some of the features of it, which will give the interventional cardiologist, radiologist, surgeon, angiologist, whoever it may be, the ability not to have to switch to multiple devices while doing the case. It's aptly named the GoBack catheter because I think you can go back to different options, as Mr. Posen educated me just a few minutes ago, and it opens all the options for you to be able to not only have directionality but also the ability to use needle technology to maybe cross from a subintimal plane to a true luminal plane. But again, we'll go over the nuances of this device. I'm very, very happy here to have Dr. Kapoor, who's again our director of endovascular services in Mount Sinai St. Luke's. Next to him is Sri Avadani, who is I'm very thrilled to announce that she's going to be joining us here at Mount Sinai as part of our team next year. And then we've got Ray Lascano behind us, who's always with us. We've got Elizabeth Holton and Damian Cabrera and our entire team. So welcome. And without further ado, I want to present this case. It's not again, technically, I think compared to the cases we've done in the past, it's not a very challenging case, but I think the beauty of this is to really demonstrate the device and demonstrate what the device can do. So go ahead, Shreya.
Good morning, everyone. I'm just going to go over our case here. Our patient here is a 65-year-old female with history of hypertension, hyperlipidemia, a prior stroke with no residual deficits, coronary disease, ischemic cardiomyopathy, and PAD with multiple prior endovascular interventions. She presented with a non-healing gangrenous left great toe ulcer. As you can see, it's more on the plantar surface of the foot. No erythema, no systemic symptoms of fevers or chills, no drainage from the wound. Rutherford category 5. Her PAD history, she's had a prior left common iliac stent placed in 2019, and also a left SFA drug-eluting stent, and also a DCB of the left popliteal back in 2019 as well. And she also had right-sided intervention a couple of years ago. She was a former smoker, but she quit 20 years ago. No other alcohol or drug use. In terms of her exam, fairly benign. She was euvolemic. In terms of the ulcer, it was dry gangrene with eschar on top of it. She had monophasic Doppler signals on the left DP and right PT as well. These are her medications. And this is a diagnostic peripheral angiogram that we performed a couple days ago. As you can see, the right side is also occluded, the SFA, with essentially two vessel runoff, perineal and PT. Her iliac stent is patent. And coming to the side she's symptomatic on, she has in-stent occlusion of the left SFA from the ostium, reconstituting distally in the SFA via collaterals from the profunda with one vessel runoff. And we can go over the diagnostic, the images that we see.
In this picture, I see the AT.
Okay,
fantastic.
Do you want to?
Well, so, as you can see, so, I mean, obviously it's an ISR case. The challenge is really going to be looking at the below knee, and hopefully this new catheter can help us. So they have two different forms of the catheter, but let's go over our anatomy here in the new machine. So you can see the DSA shows here, you've got an occluded right SFA, not irrelevant to this case. Next. So you can see here, Rand, next. So we've got a 6 French sheath up and over next. We did an initial shot, shows that you have the in-stent occlusion of the stent next. Then you've got a reconstitution at the above knee popliteal, as you can see. So it's basically a proximal ISR and a distal ISR restenosis next. And more importantly is the foot, right? You've got dry gangrene of the foot, so we need to find the real takeoff of the AT. In the other one, I thought I saw a wraparound AT coming around. We're going to have to really look at that film one more time. Next. And then over here, you can see that the foot has the dominant perineal coming into the foot, giving rise to the anterior tibial artery right there. But also the posterior tibial artery does come back, and that's probably the one that's going to supply the plantar aspect of the foot. So we're going to have to get down there and start digging on that one. Whether we do it now or we do it offline, we don't know. But let's go a little bit to the catheter, Shreya, if you can play the video.
Yes.
And I just want to show you guys the catheter. So go back to the so everybody can see what we're going to do. We have this whole presentation. We're going to go about the devices, but let's talk about the catheter a little bit. There you go. So basically, this catheter is going to encompass a lot of these devices that you're seeing that we're going to talk about, which is kind of interesting. Here's a GoBack catheter. So obviously, it's a 4 French, which is the SFA system, a 2.9 French single lumen crossing catheter with 0.14 for the below knee, 0.18 for the above knee. For antegrade and retrograde, they got 2 lengths, 120 and 80, depends on whether you go antegrade or you go up and over, and the nitinol stiff can be extended. So you can see here in the handle has a slider, and what I'm going to call is a stopper. The stopper is going to stop at 3 different notches, or the needle length selected, there you go. And the first one is going to keep it straight. And as you go forward, the second and the third one are going to go ahead and increase the curves of the needle. So if you do get into a plane where you need directionality, you can actually direct the needle in one way or the other. The lengths that it comes out is initially, 3 centimeters and 7 centimeters. I'm sorry, 3 millimeters and 7 millimeters, forgive me. And you can see it's torqueable to 360. So when you torque it, it's important to retract the needle back into the catheter housing to actually torque it. And how you're going to see it is you're going to look at the C that's going to be available on your fluoroscopy as we torque it. That C is going to allow you to show the open aspect of the C will allow you to see the direction in which the needle will fire. And for the lack of a better word, what Avi called as the stem of the C, or the circle of the C. If the circle of the C is more open or thinner, that means that you're actually in a better angle and you're not off the vessel. Again, there's going to be a learning curve, and we're all going to have to go through that, but with great guidance, we will. But the exciting part of this catheter for me personally, and I know Vishal and I talked about it, is the ability for us, and there you go, there's the C being demonstrated right there. And you can see how the thickness of the C is going to show you where you are as you rotate, and you're going to be able to align the needle with the actual vessel and be able to fire. Again, the guide wire has to be pulled in into the catheter housing while you rotate it. So this is what they recommend. And again, we'll figure it out while we use it, see which way it works well. Again, my good friend Andre Schmidt called us and asked us to try this, and I think obviously he's an incredible operator, so it'll be fun to see how it works in our hands as well. Again, it's a wonderful catheter, and I think it's going to fit well into our bag, and hopefully we can do it justice by demonstrating it properly. So again, so Karthik, what our plan in this case, you can stop the video for a second, we'll come back to it. Our plan in this case is to go ahead and go with a 018 wire, which I know we normally don't use. So we've picked up one of the Connect families of wires here, and we're going to go into the vessel, and we're going to go ahead and introduce the GoBack catheter over the 018 wire. As we introduce the GoBack catheter over the 018 wire, Vishal and I discussed this, our plan is going to be able to go with the straight tip rather than the curved tip initially. And this is going to allow us to be able to, direct this catheter and try to keep it central luminally. My plan is really going to be just to push this, because I have a needle that's good, that's quite sharp, that's going to assist me in being able to get this in, and then we're going to go. So give me the GoBack catheter, guys. Mm-hmm. So, and then I'm going to try to just pierce straight through into the stent. Now, if I go off to the side, then we're going to go ahead and use the other technology. But I am going to, before I enter, show the different configurations of the catheter by opening the needle and showing you which way is what. My hope is that I get beneath the stent strut, which we know happens often in these cases. Don't let the wire go forward, please. Mm-hmm. Which we know happens often in these cases. And this is where I think this catheter will have great ability to be able to do it. We're having a little bit of trouble getting up and over.
Right at the bend, it's an acute arch.
Yeah, it's an acute arch, yeah. Let me give you a little... Huh?
Sure. No.
Okay, that's okay. We'll
so you can probably pull the sheet back and push the catheter a little bit.
Yeah,
you can change the angle.
That's what we're trying here. Yeah, with any crossing catheter, this is an issue. Yeah, unfortunately. Yeah. Unfortunately, yeah, this is one of those issues.
Should go through.
I just have to pull.
Yeah. I don't want to fracture the catheter, God forbid. This is a challenge with all of them, as we know. We've got, this is obviously a stiff wire, the 018 wire. We could try with let's torque it.
Yeah. Let's change the direction.
Yeah, let me change the direction here.
Let me pull the sheet. Shay, you want to hold the wire?
Mm-hmm.
Yeah, I'm going to do that.
Uh-huh.
So what I'm going to do is you push. I'm going to pull it back just a touch, and you push your catheter. So it's like
push and
change
pull.
the angle. Yeah, exactly.
Yeah.
There. See?
There you go.
Beautiful.
That's it.
Yeah, I know. Just wanted to be gentle.
Yeah.
Wanted to be gentle.
Yeah.
So that's a good demonstration of
it's just like when we use the Outback and all the other re-entry devices, we do the same thing. They're very stiff at the transition point.
Right.
I think PK, because it's a new device, I think you didn't want to push it, so makes sense.
Well, it's not a new. It's just I'm a safe operator. That's why I didn't want to push it.
Yeah.
I think that this is something that obviously it takes experience to do. Okay, and you definitely want to be careful.
You want to put the sheet down?
Yeah, I will. I'm just going to leave it there for now. I don't need much.
Okay.
All right, so I'm going to go ahead. I'm going to mag up on the catheter. I'm going to enter in a little bit. Ray, fix the sheet, please, so it doesn't come back. Okay.
Slide it over.
Okay. So I have a lot of tension on this wire, which is interesting. I think that may be because of our
acute angle.
Our acute angle.
Yeah.
So now what I'm going to do is, if you can zoom in on my hands, guys, over here. Are you there? Okay. So you see this red switch here? This red switch is going to give us the I believe the 3 different configurations of this. The first one,
7, 11.
right. The first one is straight, which is the 3. The second one is going to be slightly curved, which is the 7, and the third one is going to be more extremely curved, which is the 11. So what I'm going to do is I'm going to push it in first. Oops, that was too much. As you know, I'm not a very subtle guy. So there we go. So there's number 1. So I'm going to go forward. Oops, too much again.
Let's mag up to show the seat.
Yeah, I want to show the needle here.
Yeah.
There you go. Okay, so that is, I guess, relatively straight. So we're going to go forward with this needle. Give me a little bit of dye, guys. Perfect. Okay, I'm off to the side there. So I'm gonna pull the needle back. The beauty is you can actually torque it with the needle back.
But there's a channel there. Would you use the same? Would you use the wire to just get into the channel, PK, or?
I am just going to push it into the channel like that. See? So right now I'm in the channel.
I guess.
I thought I was further in than I was. There you go. Now we're good.
Yeah.
Now we're going to come out with this at 3.
I guess the only thing they'll tell you is not like a
There
one-to-one
you go.
torque. So you're going to see PK flip multiple times to change the directionality of the.
The interesting part is how we're going to... Now, Avi, can I twist the whole catheter as a whole? Yes. So I'm going to go ahead, twist the whole... There it is. And the beauty is you can actually inject through this. Let me go with the wire a little bit. Give me another wire here, guys. Okay.
Yeah.
Sheared.
V18. Or you want the same wire?
I want an 014 wire. I want an 014.
Command.
Make sure the wire is not in here.
Can we use command is a hydrophilic wire. Should we use a hydrophilic wire PK for this, or?
I think we can use a hydrophilic wire, can we not? Because we use hydro. Give us a command.
Okay.
Yes, of course.
I mean, in general, remember,
give me a command.
Like in our re-entry devices, usually we don't use a hydrophilic wire.
Command wire?
We tend to use
That's a
more of
command.
a steel core or aluminum core wire.
This is command. Command.
I'm sorry.
Yep.
My bad.
Yep. No. Well, re-entry devices, we use a 014 wire, hydrophilic wires all the time. I use it all the time. And I think that's a misnomer. The potential of shearing is exactly what Mr. Posen was saying, is when you're out in the needle. So
Right.
if you use it in the proximal body, I think you're fine. But if you're out in the needle, then of course you can shear the wire. It's very important. So I don't want the audience to be thinking that we can't use an 014 wire with this. Of course you can. Okay, give me a wet one, guys. Ooh. It's a very... So I think this bifurcation is quite tight, giving us some issues here as we go up and over.
I get a new one.
A new command?
Okay, that's fine.
You good?
Yeah.
Okay.
I just need a wet one.
Oh, sure.
It's going just fine. So you can see the needle is slightly out.
Correct.
Yep.
Yeah.
I'm just going to use this to advance a little bit further, the wire. Yeah,
Right.
just to make sure that I'm in the vessel. Nope, I'm not in the vessel there. So I'm in the CTO. I'm going to pull the needle back, and then I'm going to torque the catheter. And see, now I redirected the catheter where I want to go. So now I'm going to stop. I got it.
Okay.
Yeah, I'm going to slide it to the CTO part, which is right about here. I feel like we're kind of off here. So I'm just going to try to torque it, pull the catheter into the housing. You see those 2 dots? You want to pull it back. My hope is that we can just go straight with the needle, which is kind of what I'm hoping. Well, no, it's a straight part of the needle here. So, nope, I'm off. Okay.
So it's like you can actually push it with your needle out.
There you go.
Start the straight end of the needle.
It's actually a little bit better here. Avi, can I track it on this wire with the needle out or no?
You can, yeah. But once you're in the right place, put the needle back and use it as a support cup.
Yeah. Exactly.
Okay.
So we pull the needle back, and
Yep,
then
and then I'm just going to use it as a support catheter. It's not going. Yeah, it's very tight here. Yep, pull back again.
That's probably your CTO end, right?
Yeah, this is the CTO. I'm just trying to figure out where it goes here.
Why don't you
Little
take
dye
that
here, guys?
channel, PK?
I'm going to. I'm just going to take a little bit of dye just to see where it is. All right, there it is. Okay, we're on the same path here.
So you can use it like a blunt dissection straight.
Yeah, that's what
and
I'm
a
doing
support
here.
catheter.
But you can see here it's
I think the angulation of the sheath
Yep.
itself is also
the angulation of the
kicking you
sheath
back.
is, yep, kicking the catheter. I agree.
Hmm.
Nope.
No.
I'm going to come out. Now I'm going to torque it a little bit.
And also,
There you go. Look at that. See that?
Yeah, wow.
See, I was able to torque it right into the plane there. That was beautiful. See, Avi, that we went right from the subinterval to the regular.
so
So now the question is, will it cross?
I guess we pull the needle back.
Yeah, I
and then-
pulled the needle back. Let me just advance
little
it.
bit length.
That was very nice. Let's walk this back a little bit. Let's
Yeah.
walk the needle back. And like Avi said, very positive on the sheet. Let's see now.
Oh, it's tracking.
Yeah, it's tracking very nice. Wow, very nice. Very nice. Okay. Very nice. Nice, dude. Not a difficult case, I admit. But truthfully, we were in the subintimal, we poked into the interval. So that was very nice. So normally, listen, it's not a difficult case. I agree with you. But what I'm saying is this part is very interesting. Now track it down, because we were able to use the needle to come out of that plane that we were in and poke back into the real plane. Now we have to re-enter here. So let's see if we can use it here. A little die now. Okay. Do a roadmap. Okay. Very interesting. Okay, inject.
So one thing to note, Karthik, is the distance between the maximum needle out tip and the center line is 4 millimeters. So that'll give you an idea how far your tip is outside the center line. So you know how much you are entering, re-entering. You know how you have in other devices certain markers?
Right.
If I'm not wrong, right?
Right. So, but the only interesting part here, at least from what I was feeling, and you guys will feel it as well, is that I thought it would be easier to push with the needle out. It's not, because it does get caught in tissue. So you need to kind of navigate the track to find where we're going. I thought with the needle out would just be push it straight, it'll just go straight. It doesn't work quite that way. I don't know in Europe if they had the same experience. It's kind of interesting. So I'm going to just pull this back here, and I'm just going to push it straight through into
so with
this.
the needle, you kind of make your path.
See, so I'm just using blunt dissection here, Karthik. I'm just going to dissect bluntly till I get to this path here. Now I want to show the re-entry capacity of this needle. Maybe go a little bit further down. Let's see. I want to get to the side of this vessel to really show it. That's too much to the side.
Work both ways.
Yeah, so let me try to put the wire out here.
Can you take a loop and just dissect it to the level of the vessel and then...
Well, we'll see. I mean, he's trying to... That's the point. He's just trying to probably find a plane to see if he finds something early on. Otherwise,
yeah, I'm just going to see that's too far. You see that? I don't want to be that far away because it's a 7-centimeter needle. So if it's 7, it may not get that close. Here, this is closer. So I'm going to go a little closer now.
I guess
okay. A little bit more closer. There you go. There you go. Now I'm close. Okay. Okay, good. Now I'm going to try to use it as a re-entry needle. So this is when I think we need Avi's help because it's our first time using it. Off-road map. Yeah. So mag up for Avi so we can look at it. So I'm gonna try to show you that C. So the needle, the C is up top, Avi.
Yeah.
Okay, so now you see I'm gonna rotate it now. And the wire's back. When I rotate it, the C is gonna point towards where I want to fire the needle. Right now the needle is gonna fire away. Okay, see how it's rotating the C up top?
Right.
So now what I'm going there you go. See the thin part of the C, that's pretty thin right there for me, right? I'm gonna keep that. I'm just gonna fire it initially, okay, which is not enough. I'm gonna go to all the way here.
I locked it. You locked
Forgive
it.
me.
Yeah.
Okay.
Okay. Wow.
Okay, let's see now.
You can actually push the whole catheter if you don't feel
right, I just want to see if I'm in. I think I may already be in. It's interesting that the wire gets quite stiff because of the little die, guys.
Mm-hmm.
There's a very diseased segment. Okay, so we're through and through here. So we're going to pull back the needle a little bit.
Now, yeah, it moves the vessel. You can see.
That's good. This might work. Not quite. Posterior.
Mm-hmm.
Uh-huh. Same problem. Okay. So this is kind of the advantage here. I'm going to come back a little bit more. Same problem. It's just taking into that plane. So let's do a road map. Mm-hmm. Okay, inject. There you go. Okay. So,
probably still in the
so I'm in a very diseased segment. So I'm kind of challenging Avi's catheter as hard as I can here. But that's good though. He likes a good challenge early in the morning. Okay, so we know that's not the plane. Okay, good. I'm going to retract the needle, and I'm going to go further down now into the segment. let's say right there. And now I'm going to fire the needle again. And I got the C, again, I want you to notice the C pointing towards. Okay, maybe. Oh, same problem. So I probably might have to torque the C a little bit more towards, make it thinner. That's too open there.
Do you think you can go a little bit more down and re-enter into the segment?
Yeah.
Because this might be
I mean, I agree with you.
Looks like yeah, that's probably a good spot.
I'm a little too deep, I can tell.
A little too push.
Yeah, see? So I
Yeah.
need to just withdraw the needle a little bit.
Because looks like that spot. Yeah, that's probably better.
Yeah, I think you're right. It's a lot of disease segments, so we just.
Oh, yeah, I'm trying to give it the most challenge here. You know, try to make it interesting for the audience. But it's definitely difficult. I mean, in the sense that this is not an easy re-entry. I just think I'm in the wrong plane still. I'm going to keep torquing down a little bit. I'm probably still firing in the same plane.
Right.
Yep.
So what would happen if you change the C directionality a little bit because you want to maybe you want to go a little bit more posterior or anterior?
Let's learn together here. Let's go to another view. Okay. Let's go roadmap here, guys. So this is interesting. So we're using one device. It's a cost savings, right? We're also understanding where our limitations are. Okay. And you can see here, obviously, it's a very diseased vessel, but that's part of the challenge here. So I'm going to torque the C now.
Can you push the catheter a little bit more down, PK,
Yeah.
and see if you can get to that normal, kind of subnormal segment? I think nothing is normal there, but
No, I understand what you're saying, Karthik. I want to try to torque the catheter and look at the C move. So it's important to fix your base as you torque. So you see the C is pointing towards the wrong direction now. So I need to bring it all the way around, and I'm fixing my base. And now you can see what we call is the stump of the C, for the lack of a better word. Okay, now it's pointing. There you go. Now I'm pointing toward it, right?
Yeah.
So now I'm going to fire. A little dye now, Shreya? A little bit of dye, just to demonstrate here. So we're kind of far away.
Yeah.
But let's see. You see how big that needle is?
yeah, 7. You almost went to 7, right?
Yeah, I am at 7.
Just
So this is when Avi was saying we can push it as a system into the vessel, but I'm hesitating to do that at this stage because I feel I'm a little bit far away. But let's go to another view just to make sure we're on the vessel and not anywhere else, or not through the vessel. Okay, I'm going to go a little bit more. Watch your knees, Ray. Okay. Okay. All right. Ready? Let's do a nice DSA.
You want to
Ready?
use it?
Inject.
Hold on one.
You're on roadmap.
Huh?
No, you're not on now.
See, now we're through the vessel. You see that? Either we're on top of the vessel or we're through the vessel.
Yeah.
So what we do is, why don't we just pull back a little bit the needle here?
Rotate just a little bit, like 45 or something, and then see if you get better.
that looks more favorable.
I agree with you.
Yeah.
So maybe a little bit
So I'm
more.
going to rotate a little bit. Can I rotate with the needle out or no?
I would suggest you put it back in.
Yep.
Rotate a bit. Come on.
Okay, rotate a bit. So I'm going to rotate
Fire.
again. Now remember, I'm not at a C now. See, now I'm at a C. You see that? So that's what Avi's saying. So I'm going to rotate a bit.
That's good.
Let's
That's
see
too
now.
much out again.
Maybe too much out again.
Yeah. Maybe we'll come back a little bit.
Yep.
more.
Come back a little bit with the needle.
Yeah, I'll try to probably go a little bit more posterior
Yep.
if you can, just to give you a normal segment of the vessel. If you,
Oh, I agree. Yep, still the problem there.
yeah.
Okay, let me just pull back and give a little bit more posterior, as Vishal was suggesting, which makes sense right there. Kind of like that.
That looks good.
But I think you're still far away.
No, we're in. I love that. Beautiful.
Beautiful.
Nice.
Very nice.
What do you think, Avi? Did we learn?
I think that you have a lot of courage to do the first case live. This is great, but it's a learning.
No, but Avi, I think the point is it's a very novel device because you're allowed to do multiple things in one, and I think this is great. It's a good demonstration. Okay, so now we're going to walk it back. So now Avi, the wire's out. I can pull the needle back?
Yeah.
Okay, good. Okay, so now I'm going to pull the needle back, guys.
Hold on, let me see.
Okay, now I'm going to go down, make sure I'm not in a vein, right? Like, okay, there you go. So it looks like I'm pretty good. Yep, looks like maybe in a vein here, but we'll see. No, maybe in a collateral or a vein. Let's see. Because we're definitely, all right, little die, guys. Just make sure where we are. Looks good. Yep, we're okay.
Yeah.
All right, good. We're okay. So now let's walk this back.
That's true. If you become progressive, you can actually go into the vein.
Well, exactly. We can create a nice fistula.
We can't exchange
And
the
that's not
wire.
what Avi wants us to
We
do.
can't exchange the bare wire.
Oh, really? How interesting. So what Mr. Posen is saying, that it's not approved, but it's off-label, and it can be used in multiple different ways for other areas. But I guess it's approved for re-entry, right? So I guess any way you need to re-enter, you're fine.
Well, technically, we could have pushed this down and used it as an exchange
Yeah,
catheter.
I already came out with it. Yeah, you know, another
what
point
Shreya
that
suggested.
Shreya made, which is very smart, is that I could have pushed this down and use this as a exchange catheter for my filter. So now that we use this brilliant catheter to cross, we're just going to change this wire out to a.
Does the bare wire go through this, PK?
Yeah. So on.
A bare wire should go through.
it's an O&8
because it's an
system.
O&8 system.
Okay.
So now the question is, let me tell you what we're going to do because it's beyond the scope of this case. We're planning on Karthik and Sardar using the Rotarex catheter to clean this up. But in the meantime, while Vishal and I and Ray do the Rotarex, I'm going to have Shreya go through some of the other catheters, and then we can discuss the beauty of this particular catheter and how it may fit into our algorithm. Shreya, can you start?
Yep.
You have the wire.
Mm-hmm. Careful. Mm-hmm. No.
That's where the re-entry was.
Okay, give us a Terumo Navicross, guys.
So I'm just going to skip over the wire-based crossing methods because we've covered it in some of our previous cases. But some options include antegrade wire-based crossing, antegrade dissection and reentry, retrograde access and wire crossing, and also other CTO techniques like the Safari cart, reverse cart, and also transcollateral crossing when there's options. But the other option is using crossing and reentry devices in CTOs, and here's some of the available devices here for CTO crossing, including the front runner, which basically uses the concept of micro dissection through contains jaws at the tip to allow, and then once you're across, you can take a catheter over the device and allow for just a wire placement. There's also an Ocelot device that incorporates OCT guidance that's built into the catheter that helps you figure out where the lumen is to help cross the CTO.
Perfect.
There's also a TruePath device that has a diamond-coated tip that rotates and essentially creates micro dissections in the CTO to allow for distal true lumen entry. And the tip is also steerable in that case. There's also the laser Turbo Elite that basically uses ultraviolet light to allow for both crossing and debulking the CTO, essentially as described in the step-by-step approach in case of CTOs. There's also a crosser catheter that again uses these micro vibrations to pulverize the CTO and create a channel across it. And also the Avenger devices, again, the Wildcat and the Kitty Cat for below the knee, basically using hydrophilic coated catheters that basically the tip can either manually or by connecting to a motorized unit traverse through the CTO. There's also a Viance catheter that we have actually used a couple of times before that you can basically essentially using a blunt tip dissection, you can also advance through the CTO. There's also a few re-entry devices that we've talked about before. The Outback, the N-Tier, Off-Road, and Pioneer. The Outback basically essentially uses the same needle tip that can be curved and basically uses these LNT radio opaque markers to orient your needle towards the true lumen and pass wire through it. The N-Tier and off-road catheters essentially use a balloon wedge that's inflated into the subintimal spaces, and in the case of the N-Tier, the wings point towards the intima, 180 degrees on either side, to allow for the wire to pass. And there's also the Pioneer that has a built-in IVIS, and that is now also 6 French, that can guide, that you can use to orient towards the true lumen, and essentially also uses a 3, 5, and 7 millimeter needle length to re-enter the true lumen. This is just a list of all the devices and their profiles. And that's really it. Some literature on, we don't have too much data on subintimal versus interluminal crossing. Just some registry data from 3 different groups that basically showed in terms of patency rate and outcomes, no significant difference. And in the case of this registry, basically subintimal approach showing higher procedure time, but however there's another registry that shows the opposite, being the interluminal crossing having a higher, longer procedure time. So it's still debatable. And that's really
excellent job. So it was a good overview of all the different catheters that are available. But look, I mean, I think, you know, our theory on CTO crossing devices is very simple. I think you need to be facile with 1 or 2 of them. I think you need to have a little bit of respect towards the cost of these catheters, and how can you say use the catheter efficiently while at the same time saving some cost. I mean, it's very expensive. So, you know, this catheter is very interesting, and I agreed to do this case because honestly, it brings to light a lot of different things that Shreya talked about. Well, don't watch the wire. Is one, I think Shreya talked very clearly about crossing, right? So it allows the ability to have the straight tip and the ability to go ahead and push this catheter bluntly. You know, and makes it a very facile crossing device in terms of the ability of this. Go ahead, do a pullback while I talk. So this way you can actually clearly see that it works as both. The second part is that this catheter can also be used as a re-entry device. Inevitably, you're going to get a subintimal, and I think part of true crossing a lesion, and this is a very easy lesion, the complex lesions, you know, you are going to be subintimal through much of the area. So it's important for you to be able to go ahead and come in and out of the lumen and be able to use the needle directionality and the length of the needle, which is very nice. This particular device, which I really liked about it, is the fact that I can adjust the needle on the fly. Of course, you know, the Pioneer catheter is wonderful that you can use IVIS, but you saw in this very difficult arch, using simple techniques such as pulling the sheet back and pushing the catheter. And I was a little concerned because obviously the first time I'm using the catheter, I didn't want the catheter to fracture, but it performed really, really well. You're able to get it into the vessel without a problem. With the Pioneer, with the length of the IVIS on the front, it might have been difficult to go up and over. Outback, in my opinion, is a little bit stiffer than this catheter. I've used a ton of Outbacks in my career. So I think that, I think with the balance being of the two, I think that you have a nice little niche with this catheter. I don't know the cost. Obviously, that has to be discussed with the company and so on and so forth. But here's an IVUS again. Go to the IVUS, guys, as we do the run. Vishal is kind enough to do the run. You can see here that we are subintimal in parts of it, and we had the re-entry, especially distal, and we'll play it again. And you can see that for the majority of it, though, we're well within the vessel parameters. The catheter performed very well, staying within the vessel. And you can see inside the stent, there's not really much tissue. It shows to me that the occlusion occurred distal and proximal to the stent, thereby causing stent failure. A little bit of tissue there. And then as you come forward, you can see here, and this is where I'm curious because I believe we were subintimal, and the GoBack catheter allowed us to pop back into the true lumen, which is very nice. So you can see right there. There you go. So keep coming back. So we were subintimal. We pop right back into the true lumen with the needle, and the needle went straight into the vessel. So very nice catheter. Very happy with the way it performed.
Stop.
And play the IVUS again for the audience while we set up the Rotarex. And Karthik and Sardar, any comments on your end?
No, I think it's nice. I mean, the best part is you stayed pretty good within the vessel parameters, as you said. That gives us an edge over, I think, everything else. And I think it has multiple functionalities, and one catheter becomes crossing as well as a re-entry device. That's the best part about this catheter.
Yeah, crossing and re-entry. It's very, it's actually sweet. I like that. It tackles two niches, two difficult parts of our CTO algorithm. I guess the next step would be to work on below the knee, because the GoBack comes in the smaller, French size that allows us to go below the knee. So, I don't know what we'll be doing it in this case, but 100% I think we will try it in our lab below the knee. And I think you and Vishal and Sardar in your cases as well, you should try below the knee to see what comes in.
Yeah.
I think the only thing, since I just used it, and I can tell you that, it is stiff. You're good. The wire's good. No, you're a little plain. The stiffness of the catheter, you have to be a little careful below the knee. I think it's an advantage, and obviously can be a problem, like in anything. You always have good and the bad with anything that you use. So I think that 100% below the knee, you have to be, the directionality of the catheter will help you a lot, especially if you get distal in calcified vessels. I like the fact that we can push it as a system, which is nice as well, because that's going to help you to be able to pierce into calcified tibial vessels. So I think that'll be good. So I think there's a lot of advantages. So we're going to start here with the Rotarex. Vishal is very facile with this device. And so we have a filter down. As you know, single vessel runoff, critical limb. We believe in filter use in these kind of cases. So we're going to go ahead and start with the Rotarex. And it's not working, as always. When you're live, it always happens. So can we figure out why the Rotarex are not working, guys? It's got to be turned on. Now it's turned on. Okay, good.
One additional advantage of this crossing device is, as Ria mentioned, that you can use it as an exchange for your filter wire.
Exactly. Exactly. Beautiful device. Liz, can you watch her for any pain or anything? Beautiful device in terms of the fact that, you can use it as an exchange. Very, very trackable device. Very happy that we were able to demonstrate it, live and successfully, which is always, she's having pain?
Okay.
No pain, right? No pain or pain?
Pain, a little bit.
A lot, little?
Okay.
Okay, good. So, listen, with the Rotarex, you're going to get a little bit of pain. We were a little subintimal in certain areas. It's part of what we deal with. So you can see here the catheter is going through very nicely. And I think the important thing with the Rotarex, make sure the blood is flowing, or else the device will get very, very hot.
Okay.
And like what Vishal is doing is brilliant. Very, very short runs to allow the device to cool and then go again. And then in the stent is very important as well.
Okay, try it.
Why it's not flowing?
Yeah, it stopped flowing. So.
Okay, go ahead. That's good. Go ahead.
It's important also to keep a rail on the wire.
Yeah, it's important to keep a rail on the wire. Off, a lot of pain. You take it into the stent.
I'll take it now.
Is it locked now?
Yeah.
Okay.
It's locked.
Yeah, it wasn't locked. Go forward. Where's the pain, Liz? Is it in the foot? In the calf or in the thigh? Because the wire wasn't locked. Flora?
Okay.
So, Flora, let me see the wire.
Flora. Watch your head.
Watch yourself. Because, okay, good. The wire didn't go.
I got this.
All right. Let's advance forward.
Yeah.
Inner thigh. Uh-huh.
Yeah.
Uh-huh.
Let's start in the stent.
Yeah, inside the stent. All right. There we go. Ready?
Yeah.
Okay.
Are there any special precautions for using the Rotarex in the in-stent segment as compared to outside, Dr. Krishnan?
Well, 100% it's totally off-label in the stent. Huh?
Yeah.
That's okay. Let's just run it through once. So, in-stent is completely off-label, but we believe this is where the real ability of this device is. Okay. All right, good. Let's walk it out.
Okay.
All right, we're going to walk it out now, and we're going to take a picture. We'll show me the distal wire as you walk it out, please. We're not expecting much flow, as you can imagine.
Might help you.
Dolor, bien? Okay, good. So we're going to take a picture. We cleaned out the proximal, and then we're going to go ahead and take a picture. That's fine. Wherever it goes is fine, as long as you're happy. So give us a 4-0 long balloon, please. So we're going to balloon the length of the thing. We know we're subintimal and true luminal. Okay, and once we balloon, we're going to decide what to do. We're not expecting flow with the Rotarex because we only cleaned out the proximal aspect of it, so I'm not even going to give dye.
Yeah, I agree.
And then I'm going to go ahead and just do a quick balloon and take it from there. 4-0, what do you got? You got 200, 150, anything is fine. So yeah, I mean, I think this, as far as crossing devices, Karthik, and maybe you and Sardar can discuss the advantages and disadvantages of different devices, and we can listen. Why don't you guys start with, for instance, the Outback, and then go to the Crosser, the Pioneer, and then, because remember, a lot of the audience may not have had the opportunity to use all of them, and luckily here at Sinai, we've used pretty much every device in existence. So I think we can go over what your thoughts are on each one.
I think we can probably start with non-imaging devices. I mean, we had multiple of them. A lot of them came into the market in and out. The most common ones are Outback. As everybody knows, Outback is a non-imaging re-entry device. It's a blind re-entry based on how the vessel looks.
Up top, please.
Yeah.
We dissect it through the lumen and then put it in a dissection plane, and we try to re-enter it. I don't exactly know how. I don't exactly remember how much Outback has a reach. I think Outback, if I'm not wrong, PK has a reach of about 4 to 5 millimeters.
Oh, there
I think that's his re-entry length.
Yeah.
So you have to be pretty close to the lumen to re-enter into the Outback. I think that's one. The advantage is it's a very facile device. It's very compatible with 6 French devices, and it tracks down very well. The disadvantage is it's a blind re-entry. Again, it's completely based on your experience and of course the amount of times you have probably used the Outback.
And you need 2 orthogonal views to
two orthogonal views
with 2 contrast dye injections to confirm your whether your needle is going to be intraluminal or not.
Well, remember, in fairness, we also needed 2 views. What's wrong going on with my pressure?
Yeah.
In fairness, we also needed 2 views, right?
Yeah, I think except Pioneer, every device, if you go blind re-entry, needs a 2 views.
Withdraw and flush your sheet, please.
That's Outback, but Outback is not a crossing catheter. It's a re-entry device. The next one
what about the front runner? Did you talk about the front runner?
Yeah, I'm going to talk front runner when I speak to them about the Pioneer. So Pioneer is, again, a device which is the re-entry device, but it's not a crossing device. It's a re-entry device, but it's imaging guided. So it uses IVIS and ChromoFlow to re-enter into the lumen. The best part about this device is you have imaging to guide you through, so you don't have to take, first of all, it doesn't need dye. Second of all, it doesn't need multiple views.
There you go. Now you have rate pressure.
Everything can be done based on imaging, and you have ChromoFlow to guide you exactly. And also, it tells us exactly how much amount of length is necessary to pull the needle out of the device. So you don't have to blindly just push the needle in. You can know exactly how much length it is. Is it 2 millimeters, 3 millimeters, 4, and 5? I think Pioneer goes up to 6, if I'm not wrong. That's the maximum length of that device. Correct me if I'm wrong, PK and Sardar.
I think it was 7.
Well, what's the needle length of the Pioneer?
think 6, 7.
7?
7.
3, 5 to 7. So it's
3,
very
5 to
the
7.
GoBack
That's what
is
it
very
is. Yeah.
comparable, which is very
Yeah,
nice.
pretty comparable. So again,
GoBack is out to 11. Excuse me, I'm corrected, and it's important. I want to give right information. So
Yeah.
GoBack is 11. So it actually gives you a little bit more of the length than the Pioneer. You're already down. Yep. Yep. So which is very nice, because some of the advantages of when I used to use the Pioneer was when I was too far away from the vessel and I couldn't reach, and now with having 11 it gives well. So that's nice.
And to talk an advantage of this device, we were able to see the needle very
Where's
very
the distal?
clear. With the Pioneer, not with the Pioneer, with the Outback, the needle is not very radiopaque.
Right. I agree with you. I definitely agree with you. 100%.
So again, yeah, go ahead, PK.
No, I'm laughing because with the newer imaging, we're unable to see the balloon because it's such a large field of view that we're trying to figure out where the balloon is. You know, our eyes have to get used to it. Mag up, Ray, a little bit. There it is. There's your proximal dot. Yeah, it's so interesting.
So to continue with the discussion, the re-entry device, again, now this GoBack catheter is a re-entry device. So crossing catheters now, there are multiple crossing catheters which are available. The one which just PK said, but the crossing catheter is a front runner. Front runner is not a re-entry device. It's a crossing catheter. So front runner acts more like it's one of the first ones, I think, which came into the market. So it kind of pierces through. It's like a Pac-Man device, I call it. So you basically go into the device and it opens up like a Pac-Man, and it eats and it tears through the proximal cap, and then you basically close the mouth of the Pac-Man, and then you go in. So it keeps creating its own channel by opening the mouth like a Pac-Man. That's exactly how it works.
Well, it's actually a little bit more of a reverse Pac-Man because it opens and pushes aside the plaque, and as it goes through, it doesn't necessarily bite the plaque.
Yes.
So it pushes aside the plaque, as you go through, which is an important concept. Go ahead.
And then
leave the wire there. Why are you messing with
again, it's not a re-entry device. So if you get into a plane, then again you have to use another re-entry device to get into the main lumen. The other crossing catheters, which is a crosser. Crosser is great.
DSA.
Crosser can be used. Crosser is connected to an electrical pulses, and then it keeps on swirling and swirling across the proximal cap, and it keeps its own track. All you have to do is put a little bit of pressure at the proximal cap, and it just keeps on forming its own track. There are a lot of other devices again which have been used. The other device which came into the market, we used it a couple of times. I think PK used it more than me, if I'm not wrong. I don't know if Sardar used it or not, or Vishal used it, is an Ocelot device. Ocelot device is an OCT guided device. It uses OCT as a high-range firing device to basically create a track through the CTO, through the plaque.
Capture the filter.
It was great, but the question is just a bulky device. So, and also, while going through the plaque, the amount of imaging you need through the CTO, it didn't give us much of a. But there are people, there are physicians who use Ocelot device pretty successfully. I don't know what PK had. I know me and PK did it as a live case once.
Yeah, we did Ocelot multiple times, actually 4 times as live cases.
Yeah.
The Ocelot is a great device, but problem with the Ocelot is, I mean, in our hands at least, there are like multiple great operators with Ocelot. The beauty of Ocelot is you can actually visualize the tissue structures as you go through. I think it's a little bit bulky. I think it's a little bit time consuming, at least in my hands. And I think the learning curve is a lot bigger than these devices. I think these devices, I like this particular GoBack catheter because it's very intuitive in terms of how you would think about crossing a lesion. So I think the Ocelot is a great device, but I just think that the reason it hasn't really gotten a lot of market share is because of the how can you say cost and one of the things that I said. Yeah. So I think it's also a dedicated, really just crossing device. If you get subintimal with it, it's very difficult to re-enter. So here you have the multiple different aspects of crossing and re-entry to get back in as well. So it's a good point.
But
so
I think after all these PK, I think this catheter, the edge which this catheter has is you can cross and re-enter with the same catheter. You don't have to switch. I think the cost savings is pretty significant.
Yeah. Oh, yeah. I mean, we don't know what the cost is. Hopefully, it's going to be priced competitively, as they just said, and I'm sure they're also going to try to make it as much uptake as possible. But again, it's going to be negotiated between the hospital and the company. So I think that should not be a thing. We bought it in immediately because we felt that we were able to that it added a little bit of how can you say, a dimension that we didn't have with our current devices. So right now, let's get back to the case quickly since we're talking about this. We're doing an IVUS measurement. You saw the runs. The runs clearly show that there was dissection, which we expected because of the subintimal nature of our distal cross especially. We know that this failed, and unfortunately we don't know the mechanism of failure, which I don't know. I wish I did. So I think the question here would be is, do we stent or not? So what I'm going to do here is I'm going to suggest to Vishal that we balloon the distal and put a Zilver PTX at the distal and then see how that looks. And then the proximal, the options are you can put either a Zilver or a Supera distally, because how do you go back to the thing again? I'm sorry. To the angio. How do I do it?
Just go to
Live. No, sorry.
no X-ray settings right there, and then see.
Okay, here we go. So I want to just show you guys what it looks like. So here's one. You can see here distal to the stent. You can see here that there's quite a bit of dissection right there. And I mean, we could do a DCB and leave it if you guys think it would last. I'm not certain. The IVUS, we haven't done a post-IVUS. You want us to do a post-IVUS to scare everybody or what?
No, I think I think PK. I think the runoff is very good. So I would probably go with, and I'm pretty sure you'll come to the PT. Looks like the PT is very AT and PT both are very accessible for intervention. So you're going to definitely give at least 2 vessel runoff. So I think probably stent distal and stent proximal, because of the multiple dissection planes. I think probably would give a better idea. I would probably put a Zilver here and Zilver on the top and end with it. I think the vessel distally looks pretty robust, so I think it's okay.
Yeah. I think it's a good idea to put a long,
especially because it's a critical limb patient, so you need a long-term patency for this patient.
So the problem is you don't have a Zilver that's long enough for this.
You can put a Supera here. I mean, you can do a Supera here or DCB here. And
all right, Supera. So give us a 60150 DCB. A 60150 DCB. 60150 DCB.
And then you want to do the Zilver proximally?
And then we'll do a Zilver proximally.
Zilver proximally, and I think you'll get a very good result.
With regards to sizing of the DCB, Dr. Krishnan, do you the IVUS measurements they gave, I believe, a diameter of a little bit less than 6?
Yes.
Yeah, but I want to use a 5.5 Supera.
Okay.
Yeah.
So I want to glass
open
the 6.0 and then use a 5.5 Supera. That's my plan.
And you're going to use a 7.0 on the top. 7.0 Zilver. Yeah.
I guess it depends on what it looks like, and then we'll take it from there. So we're going to go down now. And Karthik, honestly, I don't know if I'm going to attack the PT at this stage.
Yeah.
I may bring back the
I think so.
catheter and try it in the below knee.
Yeah.
So I think what we're going to do is we're going to improve this inflow today. Send her to the wound care. She doesn't have wet gangrene, so I think we should be fine. And then what we do is, we have time, and then we'll go ahead and see how the wound improves with this great inflow now, and then we'll go ahead and do a GoBack below the knee case to try to get this done. Everything good?
Yeah. Ninja.
Just doing roadmap?
Yeah, I just want to make sure I want to cover that lesion right there and then go back on.
It's a pretty big plane.
Yeah.
Yeah.
No, I think we're also going to have we might have some distal issues, but we're just going to cover that tight lesion around 26 or 27, and then we're going to put a Supera there.
Agreed.
It's going to be tough to land a Supera. We'll see.
Would you go from 30 or would you go more distally to the centimeter mark?
I know, that's what I mean. If you start thinking about what you need to cover, you're probably going to cover the whole thing.
It's all disease.
Yeah, I would probably cover the whole thing, probably from the centimeter mark.
No, you know what? The dot is right there, right?
The dotted right as 28.
Right by the stent. Right up top, yeah. We're just gonna do this, Karthik. I think there's an old saying that Elizabeth taught me is you can't shine poo-poo, and unfortunately this vessel is in a situation where if we start trying to make everything look good, we're gonna stent everything. So I think what we do is we'll just go through this. So we're just going to go ahead and balloon what we can.
You have to go high pressure.
That's fine. We're just going to knock it out. Go to nominal, though.
Yeah, we're not.
I'm at 4.
4 right now.
Go to nominal is what?
6.
Go to 8.
8.
again, you have to do what you have to do, right? I wouldn't worry about what's going to happen. I mean, you have to, if you're in here, you're committed yourself. You got to do what you got to do. So we're going to go to 8 atmospheres here.
8.
Because I really want to employ a supera. Show me what size supera we should take. Show me above now. Because we know we went in. Good. So we almost covered the whole stent as well, which is good. So now we're going to, so this will be a 120 supera, Karthik, you think?
Yeah.
Yeah, I think so.
Yeah.
120 should
120
do it.
should do it.
Yeah, 5'5", 120 supera.
My concern is that 21 to 24 segment.
It's going to look bad, but we don't have a significant flow limiting lesion.
I don't see expansion as much as it's supposed to have.
Yeah, it's just the eccentricity
my
of the
concern is there's
balloon.
going to be a lot of elongation of supera there. I think we should
Correct.
go a little bit more higher pressure.
Yep, I
That's what I
agree.
said.
Flora? Go on.
It's stretching, but that's where
Yeah,
the
that's
point
better.
is.
That's better. That's
That's a lot better for me,
That's
too.
a lot
I like
better
that.
too. Yeah, I like that.
I like that, too.
I mean, if you're putting a supera, you might as well tear the vessel. So
well, you have to expand the supera. Please,
Yeah.
501, 55, 150, 120.
because otherwise
Instead of
you will
3-minute
expand,
timing,
you will
I think.
elongate into the stent. So you don't
Well,
want-
I think supera is very difficult to deploy. As good as Vishal is, I think this is going to be a challenging deployment because it is a tough one. So we're going to go ahead and open that, please. Can I have a time check? Okay, we're at 9,
I
so
know
about
Vishal
an
can
hour.
do it. I know Vishal can do it. So I think that's
So we're going to quickly deploy the supera.
I don't know. I should take it as a compliment or
no. Don't let me down,
the
Vishal.
supera is as good as Vishal can deploy.
So I just want to make a little comment on the preparation of the supera, guys. I think it's very important for you, and we don't talk about this enough. You need to flush both ports, right?
Yeah.
I think it should be
You
3
really
minutes.
need to
I
be
think,
aggressive with this
yeah.
this particular device on how you prep it. So flush both ports. The other thing you need to do is really wipe it down, right?
Yeah.
You really need
The
to
whole
wipe
device,
it down.
actually.
You need to
The whole
wipe the
de-
whole device,
Yeah.
except the handle. Wipe it down completely, make it sopping wet, which I think really helps in terms of trackability and deployment of this device. So, as Vishal finishes the balloon there,
I'm going to help you.
and then we'll deploy the supera here, and then we'll go ahead and we'll just do the proximal with the silver. Get us some 7.0 silvers, please, Bill. 7.0 long silvers. What was the IVUS measurement up top in the prox?
6.5.
6.5.
6.5?
6.5
I can't hear her. Up top, proximal.
was 6.5.
I believe you. I just want to confirm. It was 6.5? Okay. Fantastic. So once we deploy the supera, I'm going to go ahead and just finish off the Zilva very quickly, post dilate, and then we'll say goodbye.
You want to take a picture first? We shall see where you have to end it.
We're thinking at 29, but okay.
with the
fine.
6
That
inch
makes
and a-
sense. I agree with you.
Yeah,
I
with
agree.
the,
That's a
with the
smart
6 inch
picture.
and supera, you might.
You'll
might
never
not
be able to
the
see.
best,
Yeah.
Yeah.
Okay, ready?
That's a good topic. That's a good thought.
Oh, it looks nice. I like it.
Wow.
Looks very
It's
nice.
really cool. Yeah.
Yeah.
Looks really good.
All
Only
right.
the very distal segment
Yeah,
after
again.
the stent, but otherwise.
Again, you can't
looks
shine the
really good.
poop, so.
Yep,
So we're gonna start at 27
That's Elizabeth
before the-
saying.
Let me do smart math.
Yeah.
I would go
smart
right
math.
by that branch, like the
Yeah.
small dissection plane, and start
Yeah,
deploying
I-
from there. Yeah.
Yeah.
So we're going to go ahead. You're going to go at 29?
Liz,
right.
I'm going to remember that. So.
Yeah, she taught me a lot of things. So it's very interesting. This is our second room here at Sinai for vascular. Thanks to the support of Dr. Sharma and the entire staff and the hospital, we've been able to get our second room, which is fantastic.
get this
I'm very, very happy that we're able to have such a great room to be able to do these cases in. Yep. Now show me where it's going to land up top.
I like the imaging also. It's very crisp.
It's okay. Flora?
Yeah.
Okay, you're going to have to go forward a little bit, which is fine.
That's
go
good. I
forward.
think it's
Yeah.
fine. You can.
I think
you can
it'll be
always
fine.
compress
I
it.
think, yeah, it'll
Yeah,
land.
it's fine.
Just compress it. Yeah, I
I think
agree.
you can always compress it.
Yep, I agree with you. All right, guys. So we're going to go ahead and deploy this supera here.
I would go
And-
right by 27, Vishal.
There, I'm right.
That's
Yeah,
fine.
right
It's
there.
fine.
Should be okay. Okay, fine.
So, Vishal, can you talk about what you're doing?
Yeah, so again, Supera, like PK said, it's a very tricky stent to deploy. So the idea is to just have a good control, half throws, and where you can see the my right hand with a little bit of forward tension through the left hand to make sure it comes out the way it is supposed to, but not too much positive tension because you can sometimes have an infolding as well. So, and the idea is you're going to see the markers of the dots on the side, and that's exactly what shows you whether it's getting elongated, compressed.
I would pull back a little bit, Vishal, because we didn't
Yeah.
prep that side of the vessel. So
Yeah, I
would
know,
pull
but
back a
that's why I
little
was
bit.
That's
pulling
okay.
back a little
You
bit.
want me to
That's
mag
all.
in?
I mean, at this stage, you're not going to pull back. You're already committed.
Yeah.
Yeah, you're already committed. Just compress
Yeah.
it. Yeah.
See, that's why my whole thing was to just start more proximally, not at 27.
But I think you're okay.
Yeah.
Yeah, that's it.
We'll balloon it. Don't worry.
Yeah.
Get us a 6015 via track, guys.
So just slow half throws.
So the best thing about Supera is it's a very good time to like take a quick nap while it's being deployed. You know,
So you can see those markers on the side.
So when the Supera first came in, PK, I think what they said was the best way to know the Supera's deployment is good if you take a pencil and put two lead lines
Correct.
on both sides of the stent.
7.
If you see a straight lead line on both sides of the stent, that's a good deployment of the Supera. So
Yeah, exactly. So you see those dot markers? If they stack up too much, it becomes like a line. If they're far away, you don't see them. For here, you can see those markers on the
I
side.
would I would compress it there, Vishal. It's elongating a little bit.
Yeah, I see.
You got a
Go a little
long
bit
way to
short.
go.
Yeah, you go a little bit shorter deployments and probably compress it there.
See, that's the issue. I know.
Again, this particular thing, and this is called infolding, really has
That's
nothing.
exactly
It has
what
nothing to do, and it was a nice technique of showing you how to deal with infolding. It just pull it back out, you'll be fine. Supera is like a slinky, and I think this will be fine.
Yeah,
So we're, this is very exciting. I think this particular part of the case.
see,
That's
the longest
why-
right
that's why
there.
we-
See, that's the area we were concerned about, 21
Yeah.
to 24.
So you can see the amount of forward tension I have. The idea is if you give too much forward tension, it infolds. So, and it really,
So go
So I'm going
try to go a
there.
little bit shorter throws than that, Vishal.
trust me, I'm
Yeah.
going like not even any throw. You're not going to see any pretty much tension amount.
And again, I think one of the things that you have to understand is like this is part of the challenge. We oversized the balloon. We expanded the balloon. It's a 5.5 vessel, 5.2 vessel actually. We put a 6.0 balloon. We went to 9-10 atmospheres. She had pain. There's obviously a recoil. So we are dealing with this, and it's going to elongate. I mean, I one of the reasons I asked Vishal to do it is because it's going to elongate. So if it was going to be perfect, I would have said I want to do it, right, Vishal?
Yes, Chief.
Yeah, I'm just teasing. It's a very challenging stent to use.
And see, sometimes what happens is look at the angulation. Now the stent starts to go on one side.
Yeah.
That's another story with especially if the dissection is spiral. You can have an issue where the stent actually see how it behaves now.
Now you're going to be fine. You're out of that
Yeah,
craziness.
you're out of- yeah.
Yeah, and then we'll balloon it with a 7, and it'll be fine. I mean, unfortunately, this is
See the amount of recoil
part
you
and
have?
parcel. The easy way out is to put a Zilver in, but the Zilver will be what's called as a pancake and won't give you a lumen. So therefore, here, I believe you can post-dilate these Superas to get a better one. I've asked for a 7.0 balloon to post-dilate this. Maybe we should have pre-dilled with a 7.0. I don't know, but hindsight is always 20/20, as they say. So
I mean, it
what
was
we're
a
gonna-
5.5 SLPK. If 7.0 would have caused probably a perf. So
Yeah, I mean, I agree. I agree. with you. I'm
Again,
not
So I don't
denying
know. I don't know who said it. Jay said it or Dr. Walker said it during the arch. Like everybody thinks you cannot post dilate a Supera. I mean, I don't know,
See
PK,
again.
what you feel. I feel we can post dilate a Supera not to just give more expansion, but more of a even elongation of the stent. I think it compresses the stent in such a way that it rearranges the stent line. So I think over time it rearranges the stent by post.
It's elongating quite a bit, obviously.
Yeah.
We're going to have to deal with it. It's okay.
So
Listen,
as soon as he
it's-
comes close to the distal edge of the stent, he can just keep compressing,
See
and then
that?
we can use a 7.
Yeah. Trust me, I'm going as slow as possible with the forward tension again to compress it.
Oh, we're going to cover the whole stent length, looks like.
Oh, you know,
That's a.
at least it'll deploy the nominal inside the stent, right?
Yeah.
Very difficult, very real world. You saw how the GoBack behaved. It went around and came back, and so you're in a subintimal plane. It's a very difficult case. In that way, it is.
Yeah. See how it.
In retrospect, maybe we should have ballooned with a 7. I don't know.
7-0, right? Yeah. I'm thinking
Maybe we should have gone with a 5-0 Supera. I don't know.
This thing is elongating as if there is.
Don't worry about it. I'll just deploy it. What else can you do? We'll deal with it. It's okay.
You want to release some tension, Vishal? Pull the wire back and forth. Pull the wire back and forth and see. So I think there's a lot of tension in the catheter too. So
Okay, now it's
there
gonna
you go,
start
it's better.
normalizing.
Keep compressing as much as you want.
Yeah.
The more you compress, the better it is here.
The last thing I want is an infolding again in a stent, so that'll ruin the whole thing. So I just want to make sure there is enough control.
That's a quite bit of elongation.
Yeah. So you can look at my throat. It's barely like 1/4 of a centimeter right there.
Get us do you have a 6.0 014 balloon? 6.0 long 014 balloon, guys?
Almost done.
Almost done.
Yeah, we elongated by about 40, I think.
Yeah, the nice thing about the Supera is you can tailor the Supera to the size of the vessel.
Yeah.
I think it's a very cost-saving maneuver. And the reality is, it's all jokes aside, it's a very difficult stent to deal with. Although you want to deal with it in these kind of lesions, it's a very difficult stent. Tough case, tough. Let's go. So we're gonna balloon this with the 6.0, and then we're gonna go ahead, and that's fine.
Yeah.
We're going to go ahead. Well, let's get a 6.0 long. Did he have it, Lizzie, or no? You have it, buddy, 6.0 long?
018 wire, 601.
That's fine. Give me that. So we're going to go with an 018 6.0. We're going to balloon this. And then what we're going to do is we're just going to put a Zilver PTX up top, but it's already going to be 9:13. So we have 15 minutes, and we'll be done. And then we'll go ahead and be done with it. So Karthik, in the literature, it's very clear. Superior elongation equals restenosis. So one of the things that we're studying right now, or looking retrospectively, which we're going to publish shortly, is the use of Supera along with DCB. So DCB in elongated stents, at least in our wishful thinking, we'll find out what the data shows, shows that there's possibly a reduction in restenosis and kind of neutralizes the effect of elongation. So this is one of the reasons I think that DCB, may be very useful in marriage with Supera, because of the fact that it may reduce the restenosis along with associated, that's been documented with the elongation of Supera especially. So this one we gave the patient DCB. Obviously we saw IVUS-wise the Zilver PTX was fine, so it's not really a Zilver issue. So here we're going to go ahead and blast the Supera out, right? We're going to go ahead and blast it, go 10, 20, 30. Okay, down. So now I'm going to pull back a little bit because I expanded that distal area. Okay, now go up. Now go up for me. Okay. So now I'm just going to go to about as high as this balloon can possibly go, which is 20. We're at 20 with this balloon, down. So definitely that's doing some help in terms of getting us a lumen. I'm going to walk it back, go to 20 again. Okay, don't worry about it. She's going to hurt. Yes, we know. Okay, down. Okay, very good. All right, now we're going to go ahead and do the Zilver up top. Give me a 7.0 long Zilver.
Okay.
So Villa looks fine. Looks good.
I think it looks very good. We'll do a quick IVUS.
I agreed.
Actually, it looks very good.
Looks very good. I like it. Nice job,
I like
Vishal.
It's a tough case. All right, DSA. Low mag.
Yeah. Nope, doesn't work. Elongated.
It always looks good after the.
I've never seen that, but it's good. No.
All right. 7-0, what size silver you guys want, guys? Roadmap?
I think it's from 1 to 10, 120.
7140 would be good, yeah.
Yeah, it starts from 1 pretty much. Even before that, I guess I have to see the marker, but.
So 7-0, 120?
120, yeah.
120.
7-0, 120. So follow up on these cases. How do you follow these cases? What is your anticoagulation strategy? What's the story?
Sardar?
I mean, follow up, we
120?
We do here for surveillance ultrasound after 1 month, and then after that every 6 months. With regards to medical therapy, I mean, this patient obviously will profit from a prolongation of dual antiplatelet therapy, maybe 6 months, maybe add an low-dose rivaroxaban to the treatment regimen with a 2.5 rivaroxaban instead of long-term clopidogrel. Cilostazol might be an option for the future, but then it will become a triple combination, and depending on her age and risk of bleeding, might be a limitation for her. Karthik, any?
No, I agree. For this patient, I would probably, because the runoff, I would probably go with rivaroxaban. Yeah. Definitely. And whenever I give rivaroxaban, I mean, I usually just give Plavix or aspirin. I usually avoid cilostazol. I don't know. What do you do, PK and Vishal?
You know, I mean, this lady was on Plavix coming in. So, you know, I mean, we know that restenosis is not a phenomenon of thrombosis. So I don't necessarily ascribe to that idea that she's a Plavix failure. So
agreed.
What we started doing now in the last couple of weeks is really testing these patients for resistance. And it's way too big, but that's okay. We got to overlap anyway. Right there. If we're gonna have to do this for resistance, and I think that's good right there, right? Oh, you want to go in a little bit?
That's good. That's good.
I think that's good. Go ahead, deploy.
Yeah.
So yeah, go ahead, take floor. So I think what we've started doing is we've gone ahead and started testing for Plavix resistance. So if they're Plavix resistant,
good, right?
then it really brings up this interesting phenomenon of what do you do? So if they don't bleed, then Effiant with 5 milligrams of Effiant with rivaroxaban for a month, followed by rivaroxaban and aspirin after is kind of what we're taking. Unfortunately, Raman Sharma, our other endovascular fellow, has come up with an idea for research.
I would pull back,
which we're going to go ahead and investigate as to how to treat these patients with PAD and the optimal antiplatelet therapy, which I think is going to be interesting. It's been studied so much in the coronaries and really has not been studied at all in the endovascular space. So we really need to look at this, and so we can come up with some evidence-based approach to how we're going to treat these patients. Nice. Okay. So we're going to go ahead.
I don't know what rivaroxaban and Effiant or Brilinta combination is going to do. I think the bleeding risk is high in general.
Yeah, so we're just going to, because we're going to balloon post, I'm just going to take a picture here to show how everything is looking for our audience.
Looks nice.
So obviously post-stent, everything looks beautiful. Again, many thanks to that GoBack catheter, the way it performed and helped us get this case done. Low mag here, guys. So we're going to go ahead. We're on the lowest. Wonderful.
Hold on 1 second.
So we're going to go ahead and take pictures here to see what we're dealing with below the knee. So you can see here we have a little cutoff going on there, which we'll deal with.
Embo, yeah.
I don't know if it's embo or if it's
spasm.
If it's spasm or something, we'll deal with that. It's not an issue.
The wire was there.
The wire was there, yeah.
And also, that's where the Rotarex. That's where the wire was when the Rotarex was not locked. So
right.
It could be spasm. So.
Or whatever it is, we'll take care of it. And then we're just going to go here. There's one area right there. So once we fix that, we'll have good flow to the foot, and then we'll go ahead and take care of the dissection or the balloon or whatever it is there. So anyway, so I'm going to conclude the case while Vishal finishes up. Bring the camera to me, please. So a couple of things here. We were able to demonstrate very, very clearly, the utility of a really novel and new device in terms of, crossing these very complex CTOs. So the device, I think, in our hands, we were able to demonstrate the utility of the device both as a crossing catheter and as a re-entry catheter. The ability to be able to torque the device, understand which plane we are in the device, and then to utilize the needle in different lengths to be able to cross had a significant value, at least in my opinion, in this particular case. Second thing, I think we talked a lot about, the different types of crossing devices. Again, I think our take home for me, Karthik, Vishal, and Sardar, is that we become facile with one or two of them, understand the limitations of each particular device, and then decide which one fits in your lab based on cost and based on your own experience. Third is, then we were able to cross this CTO. We decided to do drug-coated balloons supera distally and then a Zilver PTX proximally. You saw as we did the supera, there was severe elongation, despite our IVIS sizing of the vessel and our vessel greater than 0.75 above the vessel, showed that these can be very challenging lesions. So therefore, we discussed a little bit about the utility of DCB in these particular cases and whether drug-coated balloon technology will have an impact on improving restenosis in supera that's elongated. Fourth, we also showed the Rotarex catheter and in cleaning out the stent. I don't believe that's distal embolization. I believe that's spasm or that's a dissection, one or the other. We'll deal with it in the appropriate manner. So clearly, with our hands, Rotarex has significantly less embolization than other catheters, at least in our hands. So we're very, very happy with that particular catheter in terms of how it works in our hands. Five, we talked about the utility of the filter. In our algorithm that we published at Sinai and Jack in 2017, I think now, clearly shows that in these type of lesions, distal embolization is a real problem, and that you should consider using a filter. And again, accordingly, with the filter, cost is a considerable factor. However, you also need to figure out which filter works right for you in your lab and also with your experience. So with that, I want to say goodbye from the lab. I'd like to thank the Upstream Medical Company for sending us a wonderful representative to help us learn and use this device live for the first time. Again, it's a good demonstration that you are capable of learning how to use a device and use it effectively, even in a case that may be a little bit challenging. Second, I'd like to also inform all of you that EVIs, or New York Endovascular Symposium, is going to be obviously a hybrid course this October. You will all be receiving information. We'll be starting with the Fellows course on Thursday, October 14th, which is the Mount Sinai Endovascular Fellows course, directed by your Dr. Guja, Dr. Kapoor, Dr. Daniel Hahn, and Dr. Bhaskar Purushottam, and Dr. Ajit Rao, as well as myself and Dr. Ferry's helping out in whatever way we can. And also, the day one of the course will be Friday the 15th, in which our own Dr. Luxstein will head up the venous side of the course for NYEVS, and the arterial side will start. October 16th, the Saturday, will be the critical limb section of the course, followed by the aortic. So we will hopefully demonstrate another upstream medical case in that course, and we'll have obviously live cases from all over the world, to really demonstrate newer technologies as well. So again, from the lab, Vishal, obviously Shreya's wonderful presentation, Ray, and Elizabeth and Damien, we thank you, and we'll see you next month. I do want to say that we are going to have a live moderator next month who's in our institution, and we'll be doing a very interesting case as well. So thanks, Karthik. Thanks, Sardar. And signing off from the lab.
Thank you, PK. Thank you, Vishal. I think it was a fantastic demonstration of a new device, and definitely that's kudos to PK. Very gutsy to try it live for the first time. And I think he did a great job, as usual. Not surprised at all. So we will conclude this session. Again, please do ask us any questions we have. This case will be archived into our website by the end of the day. If you guys didn't have time to watch it, if you guys have any questions regarding the device or the way it's deployed and everything, and I'm pretty sure PK will be more than happy to answer it. If you don't know, we'll find out and get back to you guys for sure. And then the next live case is going to be on May 26th, the last Wednesday of every month as usual, and we will see you here at 8 a.m. sharp.
Thank you very much.
Thank you, guys.